Mhm. Okay. All right. Hello, everyone. It's very nice to meet you. My name is Beverly Chang. I am one of the co-founders of the Tri-State Obesity Society, and I'm here to welcome you to our first event of the roots of our obesity medicine curriculum, and that stands for Review of Obesity Topics. We're starting today with Pediatric Obesity Medicine with our experts, Drs. Jessica Williams and Nancy Trout of Connecticut Children's Hospital. And I just want to introduce them very briefly. Dr. Williams completed her medical degree at the University of Connecticut School of Medicine and her pediatric residency at the University of Chicago. She practiced for a decade in primary care in underserved communities, and as a teaching physician before she specialized in obesity medicine. She now works with patients of all ages up to young adults in the obesity division at Connecticut Children, and continues there now in the medical and bariatric track of their team in the ASMBS Center for Excellence accredited program. She is also has a passion for healthcare information technology and has earned her clinical informatics board certification, serving as the medical director for the team at Connecticut Children. Nancy Trout, MD, MPH, is an assistant professor of medicine at the Department of Pediatrics and also co-director of Cole's Start Childhood Off Right program. She completed her MD at the University of Connecticut and her certificate in global health and master's in public health at the University of Massachusetts. She has been working in the pediatric ambulatory and primary care system for about 22 years and then joined Connecticut Children's Practice in 2017 and is, as I mentioned, is the co-director of the SCORE program, which is an early childhood obesity prevention program in the Office of Community Child Health. And she is now the assistant professor in the Department of Pediatrics at the University of Connecticut School of Medicine. So I'm going to hand it off to Dr. Williams and Dr. Trout now to allow them to share their screen. There we go.
All right.
And as they get themselves set up, I just want to remind everyone that this event is being recorded and will be available for public viewing afterwards. Please feel free to throw in any questions that you have into the chat box. And we do have time at the end for questions, which I will also help moderate. Take it away.
Okay, thank you very much for that warm welcome, everybody. I'm going to turn this over to my esteemed colleague, Dr. Trout, to kick us off.
I will do the prevention and then Jessica will do the treatment. So we can just go to our first slide. Maybe.
Okay, we will try to go to our first slide. There we go. Okay.
So we're gonna talk to you guys today about maternal and child risk factors for developing obesity. I like that, you know, this is your first in the series of identifying causes, and we're starting literally from birth. So it's a good way to begin the series, I think. So we're going to talk about some maternal and child risk factors for developing obesity that we can identify early on, learn how to implement some childhood obesity prevention strategies in pediatric practice starting from birth. And then I'm going to hand it to Jessica, and she's going to talk about a stepwise approach to pediatric obesity treatment and talk about some medication management and expanded indications for bariatric surgery. We have no disclosures. But
no financial ones.
No financial disclosures.
But we still certainly will talk about some off-label medication uses when the time comes, and I'll walk you through those in detail.
So this is going to come as no surprise to any of you, but I think it's always important to start with a review of the health impact of obesity, especially with children. And we know that childhood obesity has tripled over the past 30 years, and I'm sure all of you are seeing, and we are as well, that the pandemic has not helped this. 19% of children aged 2 to 19 years have obesity, which is over 14 million children and adolescents in this country. And 8% 50% of children younger than 2 have obesity if you use weight for length instead of BMI. We also know that childhood obesity tracks into adulthood, which is one of the reasons that we are going to focus on prevention. And especially early and rapid excessive weight gain does track into later childhood and adolescence. And those kids end up having worse health outcomes than children with a normal weight. Rates are higher, as for most things. For low-income and minority children, 24% of Black children have obesity and 26% of Hispanic children. And this is old data, the healthcare costs, but there is a significant and growing impact of obesity-related illness on healthcare costs. This data is about 10 years old, and it was about 1/5 of annual medical spending. So it's probably over 200 billion now. And childhood obesity alone leads to 14 billion in direct medical costs. So it is a significant health problem that we need to try and get a handle on. I think it's really important as we all talk about DEI and as we're all kind of reeling from some of the health disparities which have come out and been made more obvious with the pandemic, that as with many of other health disparities, there are also health disparities that exist in overweight and obesity risk. And they really sort of go along this very similar racial, ethnic, and socioeconomic lines for children in Connecticut and in the rest of the United States. The prevalence of obesity increases as household income decreases. It's almost a linear relationship. And as we said, Black and Latino children, and actually Native American children also have higher rates of obesity than non-Latino, white, and Asian children. And if we look at some of the reasons, if we take a little deeper dive into why this is, there is increased exposure to risk factors for overweight and obesity in childhood. So there's a higher percentage of mothers and actually fathers with obesity. There are a greater number of single parent households and economic stresses, lower breastfeeding rates, early introduction to solid foods, which can sometimes lead to excessive caloric intake early on and that rapid weight gain, almost 4 times more screen time. So that is a significant risk, and a higher intake of sweetened beverages and fast food, which is also associated with poor access to some healthy food choices, and to some significant targeted marketing by the food and beverage industry to minority neighborhoods and children specifically. And that used to be a lot in TV, and now we're starting to see it also, in social media and on computer games and video games, and it's spreading. And so one of the things that we're going to talk about is really the need to give parents strategies and tools for information, for healthy behaviors, really from birth, that will help their children achieve a healthy weight, in spite of the risk factors that they have. So this is kind of a busy slide, but I think it does speak to the complexity of childhood obesity. This comes from Leanne Birch from Penn State, and it's a pretty old model, and there would be, but it still fits for what we look at in terms of ecology of childhood overweight and obesity. And there are these stratifications of risk, and starting with the child's weight status, there are child characteristics and risk factors. There are parenting styles and family characteristics, in utero influences, which we are learning even more about with genetics, with epigenetics, with microbiome variations and effects. And then really the community and societal characteristics. And I think, there was a talk at the last AAP conference about how we are living in an obesity society. And I bring that up to our parents all the time, both in weight management and in primary care, that it's something that we're all really fighting against. And I'm not going to go through any of these specifically, but you will have them to go back and look at if you want to. But I think, it does also point out various risks and areas where we can target interventions. And I think that's sort of the other thing that a model like this gives us. Next slide. So we do know that overweight and obesity in early childhood tracks into later life. And this is just a smattering of studies that have studied this over the years and been published. But rapid increases in weight for length in the first 6 months does increase risk of overweight at 3 years. And that's Elsie Tavares at Mass General has really looked at that. We know that children who have a BMI greater than the 85th percentile in their preschool years at ages 2 to 5 are 5 times more likely to be overweight at age 12. And severe obesity, especially, we're starting to see is a real risk and problem for these kids. And this is a pretty startling statistic, but severely obese, so kids who are over like the 98th, 99th percentile, severely obese 2-year-olds have an 80% chance of being obese by age 35. These are sort of models and kids that were really tracked out a long time, and severely obese 5-year-olds have a 90% chance. So those children sort of in that class 2, class 3 are more than like 120% of the 95th percentile, which we will get to. They really have significant risks and really need early intervention. There was a study done at Harvard that simulated growth trajectories over the next several decades, and they had computer models that they poured all kinds of data into, I think, tens of thousands of growth points, and created these models and trajectories. And they are predicting, if these models hold, that 57% of today's children who are age 2 will be obese at age 35. So we, more than half the country, within the next 2 to 3 decades. And that is pretty shocking. And then among adolescents with obesity, the most rapid weight gain very often occurred between 2 to 6 years of age. And they had that early adiposity rebound, and that is its own risk factor for obesity later on. So the Robert Wood Johnson Healthy Eating Research and the Institute of Medicine really looked at, they did some serious looking at risk factors for developing obesity. And they looked at a lot of studies going back, maternal factors, pediatric factors, and they came to very similar conclusions about where risk factors lie. And on the maternal side, moms who have a high maternal pre-pregnancy BMI greater than 26. So it's, really mothers who have pre-pregnancy obesity. Maternal gestational diabetes is a very big risk factor. Excess maternal weight gain during pregnancy of more than 35 pounds. Maternal smoking, which I was a little surprised about, but that has a significant association with later obesity development. And then obviously parental obesity, so maternal and or paternal obesity, and that speaks to sort of the genetic and some of the epigenetic factors that contribute. And then in terms of pediatric factors, definitely those LGA, higher birth weight babies, the large for gestational age, more than 4 kilos. Then the second one, I think, is really the important one that we focus on, especially in primary care, rapid weight gain. So crossing more than 2 either weight for length or BMI percentiles on the growth curve. And when you have kids that are on that kind of trajectory, they really need serious intervention, before they keep crossing, because that kind of weight trajectory does tend to continue. Higher absolute weight for length greater than the 85th percentile in birth to 2-year-olds. As we discussed, lower socioeconomic system and racial and ethnic minorities, those kids definitely are at risk for developing obesity. And then insufficient sleep, which we're learning more and more about in infants, and especially less than 12 hours a day in 6 to 24-month-olds, but that actually does carry over a little bit into the older kids as well. So there has been a big push. This came from sort of the from healthy eating research, but this is pretty much and from the AAP, but it's international. Australia was starting to do, they have a whole first 1,000 days, and the American Academy of Pediatrics has several articles and policy statements looking at the first 1,000 days. But this has been identified as a really critical time for maternal prenatal nutrition and child childhood nutrition in the first 2 years as being crucial for future health and developmental outcomes. And there really has been a focus on biologic factors, again, genetic, epigenetic, microbiome. We know that mothers who have obesity have a different microbiome than mothers who don't. Parent and community factors, which we'll talk about a little bit more, environmental concerns, including, the built environment and the safety of neighborhoods, healthcare delivery and access, infant behavior, and especially feeding practices during pregnancy, during infancy, and during early childhood. And these all are fairly crucial domains for kids developing kind of normal growth and development early on. So really looking to identify what the risk factors are so we can document them and intervene if kids start getting into trouble. And then just looking at successful interventions to prevent obesity in later life, and how do we impact modifiable conditions to make that happen. So this is from the American Academy of Pediatrics, and these are pretty much the domains that were identified by healthy eating research. And this comes from some of the American Academy of Pediatrics statements on promoting normal growth and obesity prevention. So starts from birth, promoting breastfeeding and early responsive feeding practices, which, my motto for that for parents is you provide, they decide. So really trying to sort of stop like that coercive feeding and having to finish, the bottle or having to finish whatever, they're eating, just really trying to let children lead in sort of their responsive feeding. Promoting healthy beverage consumption of water and unflavored milk for kids over 1, and avoiding sugar sweetened beverages. And there has been a whole beverage consensus statement that came out in 2019. It was the American Academy of Pediatrics, the American Heart Association, American Association of Pediatric Dentists, and the Nutrition and Dietetics, I think, and they all sort of came together to promote this healthy beverage statement. And so that's really been a big one, is trying to get rid of juice and trying to get rid of, all avoidance of all other sugar sweetened beverages. Promoting daily physical activity for all children, starting with tummy time when kids are little and trying to get them out of their, immobile devices, their strollers, their car seats, their bouncies, their whatever, and trying to, give them some space to move. And then carrying that through, through early childhood. Shaping healthy food preferences. This is crucial because we know that kids really develop their food preferences and their eating patterns in the first 2 years of life. So promoting fresh fruits and vegetables, or if parents don't have access to fresh, frozen is a really great way to go. And avoiding processed foods and added sugars, and for the whole family. And that's part of really just creating a healthy home food environment, and using the birth of a new child or having young children, as a reason to create a whole healthy, family food environment. Promoting good sleep habits in infancy throughout childhood. And as I am sure all of you have seen, and we have seen here, again, the pandemic has been a nightmare for sleep habits in little kids and in older kids, even more so. And then minimizing screen time and sedentary behavior. Again, pandemic has been a nightmare, but it is amazing how many kids at 6 months, 9 months, can flip their finger, on a screen or press the arrow to play something. So it's really, really trying to educate parents that that is not good for your child's, for their brain development. And it also isn't good, for their health. And that it, again, like really trying to counteract some of the aggressive marketing that a lot of these electronic companies do to promoting, educational screen time. There really isn't any educational screen time under age 2, and not really that much under age 5, honestly. So, and screen time it is associated with sedentary behavior. If they're sitting there on a screen, they're not moving. So this is from the American Academy of Pediatrics, which, if anyone is interested, this is a great little book, this Pediatric Obesity Prevention, Intervention, and Treatment Strategies for Primary Care. It came out of it's an AAP publication, but it's giving a way to talk to parents and how to approach obesity prevention and then just healthy eating and active living in a well child visit, and a balance approach. Sorry, thank you. Okay. And the balance, obviously, you know, is a mnemonic for the things that we're going to talk about. But so starting with belief, like how parents' behavior, parents' attitude, that definitely affects their child in terms of eating, activity, obesity prevention. And so it's really sort of looking at, you know, how parents live and, you know, what their thoughts are on their child, or do they have grandparents that live with them also, who we all know can be the worst accomplices in terms of just overfeeding children. But there are cultural differences and attitudes that really affect the way children eat and the way they're raised. So it is really important to sort of talk to parents and find out, you know, what their beliefs are on how children should eat and what movement, you know, is like in their household. But really to sort of lay the groundwork for obesity prevention and how that's important. So the A, assessment, that is just looking at the growth curve and really looking at it every visit and explaining it and sharing it with the parents. This is how your child is growing, the importance of keeping the child on the chart. That is just my whole thing. Like, we want to keep them on the chart. If they're starting to cross, we want to make some changes so that they're staying on the chart and not starting to fly off of it. And that's, you know, something that's objective that we can really look at with parents and discuss with them. Okay, the L, lifestyle, recognizing the role of family's lifestyle in supporting optimal nutrition and activity of their child. And again, this goes a little bit with their beliefs, but what is the parent's lifestyle? And I actually had dinner with one of my continuity clinic residents who's graduating, and she and her husband both have really struggled with obesity for a lot of their lives, and they have a little 1-year-old, and they, you know, and she was telling me how she's, you know, so worried about her daughter developing obesity also because the genetics are so strong. And we talked about this, like, you know, so look at what your lifestyle is and how do you make these changes? And she said they have been so strict about, you know, really trying to keep any kind of sugar out of her diet, really trying to focus on, you know, introducing fruits and vegetables and just healthy, you know, choices. It is all the HEAL, the healthy eating, active living, and that is really crucial. So it's really trying to sort of recognize the role of family's lifestyle and encouraging them to incorporate healthy changes if they're not having healthy lifestyle choices. Activity, really trying to create safe and appropriate activities for the child and limiting screen time. And that's going to obviously vary with age. In the beginning, it's tummy time. When it's toddlers, you just create a safe space for them and let them run. They have that energy, but it's really encouraging them to do that and not sitting them in front of a screen. For slightly older kids, preschool and school age kids, you know, it's starting to do a little bit more group activities, really promoting play and the importance of play, either unstructured play or structured team play, and starting to get kids to do a little bit more of that. And again, limiting the screen time. Kids under 2 should really have 0 screen times. Kids under 5, less than 2 hours, probably even less than an hour. Nutrition is the end. So really promoting breastfeeding for infants for at least a year is what the AAP and the World Health Organization actually recommends, 2 years, but at least in 6 months of exclusive breastfeeding and at least a year of continued breastfeeding. 5 fruits and vegetables a day. That goes with the 5210 messaging for Let's Go. That's an initiative that comes out of Maine that I'm sure you're all familiar with. Beverages, really, again, water, unflavored milk. And that is so important because, again, beverages are really, really marketed, and WIC still gives young kids juice. So that's another, hopefully that's going to change in their next menu update. But really telling parents, like, they don't need juice. Juice rots their teeth. That, you know, it's excessive sugar. It's not absorbed or digested in the same way as sugar in, you know, more complex carbohydrates. Portion sizes is a big one. Like, really, you know, especially for toddlers and preschoolers, they don't eat much. And, you know, all the time in primary care, I get, you know, they're not eating anything. They're not eating anything. And they're giving them Pediatric, and they're giving them all of these toddler milks that are marketed to parents heavily for, this is the secure sugar for your child's picky eating, or, you know, your child needs this for their development. They don't. And so, you know, children, you know, who are one, and that gets into sort of what the child is, the C, but, you know, children who are, you know, 1 to 3, like they are picky, they are navigating sort of their independence, they're not growing as quickly. So looking at the developmental stage of the infant or the child and understanding that that's going to impact their nutrition. I always tell parents of toddlers, if you get one good meal into them a day, you're doing fine. The rest they're going to eat on the fly. Or don't look at what your child eats at one meal, look at over the course of a day or over the course of a week. And again, if you can go back to the assessment and show them, this is how your child is growing. They're doing fine. They're eating plenty of calories to grow. That I think can be reassuring for parents. But again, also beyond focusing on the developmental stage, you have to also look at the child, because there are some kids who have sensory sensitivities, they have texture sensitivities, you know, they have temperamental challenges. So there is a lot that goes into, you know, sort of looking at the developmental stage, the temperament, the interaction, you know, that goes on between the parent and the child. And then the last, the E, is going to be talking about the environment. So a safe home environment to play, to read, safe neighborhoods, safe childcare environments, and, you know, and having neighborhoods where you can send your kid out to play, or creating walking or biking paths to school so that kids don't have to get driven, so that they can walk and bike. Childcare environment and school environment, really getting into those to make sure that, you know, they're offering healthy snacks, that they're not giving juice or sugar sweetened beverages, that they're really only doing water. A lot of them are part of the child and adult food packages, the CACFP, yeah, I think that's what it is, that actually, you know, give sort of, you know, they have healthy foods that they provide to different childcare and education environments. So that is something else. But if there aren't safe neighborhoods, or if, you know, people don't have safe places to play, like to be advocates to really try and help find that for kids, to create sports leagues or things, or like outdoor RX programs where kids can have a place to actually get outside and move. Let's see.
Okay, hold on, guys.
This one.
There we go.
There we go. So this is what we're talking about when we're talking about tracking growth and crossing percentile. So this was a patient that I saw about a year ago. It was a 9-month-old who was coming in for, I think, just a sick visit. But I happened to sort of see that, you know, if you're looking at, you know, crossing percentiles, whoops, go back. I don't want to do this, but you can see, you know, on the weight for length that, you know, they started sort of at the, you know, probably the 10th percentile, and then they're at the 50th, you know, the 25th, and then they're the 50th, and then they're over the 95th. And so that's a child who is literally crossing a percentile at every visit. So that is an alarming and curve. And that's a child who has significant risk factors, and you really need to like see them back a little bit more frequently, and really have some visits that are completely dedicated to nutrition and activity, and find out, you know, where the issues are, and really try and help parents make some changes to kind of turn that back around and get that child back on the chart. This is, the circle is in the wrong place, but if you look at the beginning of this from age 2 to age 6, and so when we're looking at the BMI curve over 2, you can sort of see how like the curve dips down until about age 5, and then it starts going back up again. And, you know, infants have sort of a high adiposity, and then their adiposity dips and doesn't start going back up again until 5. But again, like this is a child who, you know, has that adiposity rebound. Let's see if I can point it. Right at that spot. And so you can see like they're not dipping down, but they're, you know, they're going up sort of from the very beginning. And those are trends that tend to continue. And so that's a child, again, like if you're seeing that adiposity rebound, you don't want to wait until they're, you know, off the chart like they are now. You really want to sort of do an earlier intervention. think I only have two more. So this is the, these are the AAP, the American Academy of Pediatrics recommendations for pediatricians. And this is sort of in a kind of a nutshell, but really to promote responsive feeding strategies for all families and really help establish consistent messaging, nutrition messaging, that healthy eating, active living across sites. So for, for infant, toddler, preschool feeding, school age feeding, really like across the spectrum, you want parents hearing the same thing from everybody. Identifying children who are at risk of developing obesity and really tailoring preventions to that child's developmental stage and family characteristics, sort of like what I was talking about with my resident. And we do, and we do this all the time in primary care, really just try and, kind of create small interventions and changes that you can make with parents. Reiterating those core nutrition and activity messages and empowering parents to create healthy home and food and activity environments, really starting from early in life and for all of their kids and for all of the family, not just for the young ones. And then, because we all know that, when we have these visits, they're, 15 minutes, 20 minutes, 10 minutes, they're short. And so there's a limited number, of things that you can really get to. You can bring them back, but it's also really important to sort of expand out into the community and to partner with and support, dietitians, WIC, lactation consultants, preschool, schools, any kind of community resources to help patients with challenges that they face. Yep, go ahead, one more. All right, so just like looking at what is the role of primary care in the prevention and treatment of obesity, I'm going to do prevention and Jessica's going to do treatment. But, again, the weight status assessment and monitoring, really looking and advocating for healthy lifestyle promotion, healthy eating, active living, patient treatment using evidence-based techniques, which is what we, have been working on, clinician skill development. We do this talk, an expanded version of it. We've done it to all of the pediatric practices in Hartford. Like, these are the messages that we need to be disseminating to families, and also like helping clinicians, develop some skills that will help them do that. Clinical infrastructure development, working with your EHRs, like documenting risk, making sure that, you have something that documents BMI or putting it in problem lists, like things like that. And then trying to incorporate resources within your clinical infrastructure that you can then disseminate to families. Making referrals to community programs and specialty care. And this is really important. This is where we're talking about, for families who have food insecurity and don't have access to healthy programs, like trying to get them, enrolled in SNAP or in WIC, or, trying to, or Birth to 3, or, Help Me Grow. We have something called Help Me Grow, which I think is national and in a lot of states, but that will help connect families with community programs, with play programs, with library programs, with all just kind of things that gets kids out of the house and gets them kind of moving and into other programs. Community health education. One of the things our SCORE program does is we do community wellness events. And so, we go to the library, we go to the family centers, and we have health events. We do hula hooping and really try and we do dinner in a story. We try and talk about picky eating or how important it is to move with your kids. So that's, another sort of important component. Trying to sort of come up with these multi-sector community initiatives. So, touching on like health sector, but, other areas in the community, with schools, with family centers, with early care and education centers, with, we have a Hispanic Health Council, with the local food banks or things. So there are like multiple sectors within communities that all have these initiatives. And so if you can bring them together, we have something called the Hartford Childhood Wellness Alliance, which brings a lot of these different sectors together to sort of work collaboratively, to come up with initiatives. And then the last thing that I think is really, really important and that we don't do enough as physicians, but that we need to do more of, is policy advocacy, and especially around food and beverage. I think advertising and taxes, and I'll give you an example. The sugar sweetened beverage taxes, which is not a soda tax, but these excise taxes, which have been really successful in places that have done them in decreasing the consumption of sugar sweetened beverages. We had a bill which sadly I don't think ever made it out of committee, but called the healthy beverage with kids meal, so that the default beverage on kids meals in restaurants and in fast food would be water or unflavored milk, and parents could ask for something else, but they would automatically get a healthier beverage. And then, advertising. I know Senator Blumenthal from Connecticut, I did a press conference with him a little while ago about really sort of talking about limiting kind of predatory advertising to kids, especially kids in minority neighborhoods where a lot of, sugary foods and drinks are targeted. So there is definitely policy advocacy that we can all get involved with. So the legislative sessions are just wrapping up now, but a lot of hospitals have the policy committees, which is sort of interesting to be on and see sort of what's out there. And then, write letters to your congressman, to your senators, state, federal, whenever you can, because it does make a difference. And now I think I'm going to hand it over to my colleague and we're going to get into treatment.
All right. So let's do that.
Yeah.
All right. So excellent. And I would hope, and it would be wonderful if prevention were the only piece that we needed to install in our care. But it's not. About, let's see, quick math, 14 years ago, the AAP published this expert committee recommendation guideline on the treatment of adolescent and childhood overweight and obese status. This is 14 years old. You can hear it from my voice. It's well time for it to be refreshed, and there are other edits I'm hearing and close to be ready to publish state. But this is sort of the approach that we've been really relying on, certainly for almost 15 years. The idea here is to really, in the primary care home, implement well what Nancy was just discussing. This is the way that they sort of frame it. Through having children come in for their regular visits, we are going to be identifying risk factors, identifying children who are starting to have abnormal growth, and start interventions in stage 1, which is the prevention plus. That's where we're going to start to add in some tools. We're going to be implementing this with the help of the physician or maybe a dietitian in the office, potentially even a social worker, sometimes nurses, sometimes physical therapists who are excited about working in a primary care setting. It can be any knowledgeable and active person in that primary care home to give those really more specific details to the family and critically follow up. So as Nancy was saying a few minutes ago, don't just send them on their way one whole year to pass for a well child check to come around again. We're looking for a follow-up at least in the 3 to 6 month category. The child then may need to escalate therapy from there. If that's all that was needed, great. But very often we do need to kind of step it up from there. Moving then into stage 2, again, still in the primary care home, often with the same participants. But what we're talking here is higher intensity, frequency, more targeted interventions, really kind of getting down to the barriers that the family had experienced with whatever was discussed in stage 1 and trying to problem solve those. At this point, we're getting into a monthly follow-up. So we really don't want a lot of time to be passing and so seeing some of those curves that Nancy was showing a little bit ago, just continuing, unchecked. From there, moving into stage 3, this is where we're thinking of somebody who needs a higher level of care and a lot more of a true multidisciplinary team. This is the kind of program that we work in here at the hospital. I'm sure lots of other areas have these kinds of programs too. What you're looking for is a multidisciplinary team. So you have a medical provider, you have the dietitian, you have the physical therapist, and you have the psychologist. All 4 members of the team are coming in to really help implement these goal-based, structured, and monitored kinds of programming. Also behavioral modification, and not for the child as much as for the environment, really that family-based environment. And that can be as big as, including all of the extended family who takes care of this child, et cetera. So this is a rich area. I'm going to put a little extra note on this. This is where we sometimes will actually additionally use medication. And I'll tell you why in a few minutes here. Moving into stage 4, this is officially a tertiary care environment. This is definitely going to be at a referral center. It's a lot of what I said in stage 3, but a lot more intensity for sure. We're also thinking at this point of really getting into things like specialized diets. These are prescription types of diets that we're going to have careful monitoring around, and usually only for short-term kind of experience. Medications. Additionally, we're talking about bariatric surgery as well. I added a red box onto stage 4 because the way I walked this through a few seconds ago was starting 1, then to 2, then to 3, then to 4. That is the traditional method of using this structure published 14 years ago. But we're really seeing a lot of very severe obesity. Truly very severe obesity. So it's also now said very directly that if you're starting out and this patient has really marked obesity to begin with, or marked comorbidity pattern, please don't wait the 3 to 6 months in stage 1, right? This is where we're really recognizing that we need to accelerate the referral and the intensity of care earlier. And I'll tell you the data why in a moment. If I can keep moving my slides, which is okay. Some of you may know these terms really, really well. Some of you may not necessarily. So I wanted to take a pause moment and just look through the terms that we use to classify obesity these days. And what you're seeing here on this graphic here is that originally in the darker lines, those black lines near the bottom, marked 10 to 95, these are the traditional BMI curves. In fact, we were seeing a few minutes ago. You can see, however, that they're really kind of squished down. The reason that they're squished down a little bit is that we're trying to see beyond. We're trying to see how far into obesity is this BMI. So to walk it through, first of all, just basics, 85th to 95th percentile is overweight, just really quick. Above 95th is where we enter a classification of obesity. But then how deep into obesity are we? This is where we're going to use some of the terminology. Folks who are familiar with adult medicine, you guys are awesome. You roll this off your tongue so quickly. Class 1, class 2, class 3. It took us in pediatrics a while to sort of take that same framework and apply it in peds. The way we did it is we took how far above the BMI 95th percentile is that child? That's that percent. So this is really embarrassing when I always try to do this without numbers in front of me. Yay. But let's say that the child's 95th percentile BMI, let's say that that would be 25. If the child is actually oh, sorry.
If that's us, it's someone else.
Oh, okay. So we'll just do a mathematical percent. Oh, no worries, no problem. We'll do a percentage calculation of how far away from that 25, that 30 was. And
Oops.
oh,
we're being photobombed.
Oh, I guess so. Well, I'm just going to keep going. That's fine. Okay.
You guys can actually try stopping sharing, and
okay.
then you can
Hi.
share that.
Hi.
Apologies for that.
Okay, I can try to share again. Okay. We're going to try to see how far beyond that BMI cutoff that patient was, and then we're going to find whether they're in class 1, class 2, or class 3 above. This is going to give us a better ability to really track and trend with time how this patient is progressing. What sadly we are seeing here in this country is that a lot more children are starting to fall into that true class 3 obesity. And I'm looking toward Nancy because really we're seeing this both in primary care, and we're also seeing this in our referral patterns as well.
Yes.
So what we're seeing is that there are children who have been overweight. That's about a relatively stable percentage with time. And truly, there's a lot more as well. Noted recently that there might even be a slight dip in certain small numbers of age group kids that are going to have the obesity classification. However, we are really starting to see a lot more of the class 2 and class 3 obesity patterns, and these kids really, really need our help. Even with excellent intervention of the multidisciplinary level that I was discussing, a child who's in class 2 and class 3 obesity very sadly has something at best of 2 to 5% chance of a significant reduction of BMI with really good changes. So that's really not going to get that child out of a danger zone, sadly. What we're going to do then is...
I'm sorry, Dr. Williams. Let's try that one more time.
I'm happy to do that.
Apologies to everyone.
Hey.
Okay, so when we're in the context of a multidisciplinary clinic approach, and that's in that tier 3 and 4, usually after we've established a little bit of care with this family, where we're really starting to understand where these kids are at and starting to give some early interventions, really working carefully on some of the changes in their dietary and activity levels, we are going to start to think about using medications. We would use medications for any child potentially whose BMI is over the 95th percentile with a significant comorbidity, or a child who's in class 2, regardless of whether they have a comorbidity. Most people will only use a medication routinely for children who have probably already reached their pubertal development. So it's 10 or 4 and 5, or maybe around a 10 to 12 years of age. I will say the asterisk there is intended to remind me to say, if a child is very young and very severe and really significant complications, we will sometimes still consider medications anyhow. When we really measure the risk versus the benefit, those kids are really high risk. They're starting to add on cardiovascular risk. We're starting to see kids as young as 9 years old on 3 antihypertensive medications at 9 years old. These sorts of things. We've had children with cirrhosis very young from the NAFLD, et cetera. So when you measure that up against the risk of using medications, even those that are off-label, often we're going to really have a careful discussion about whether that might be the right next step. What we do is we think about the kind of medication that we have available, thinking of the mechanism of action. We weigh carefully any of the comorbidities that are known, because certainly, for instance, we don't want to pour on adrenergic medications to someone who's on 3 antihypertensives, those sorts of things. So we try to do our best choice match. We also have to sadly consider insurance coverage and the cost of a lot of these medications. We get a lot of class exemptions for treatment, so sometimes we can't use what we were hoping for and we have to go to an alternative. We prescribe for about 3 months, and then we have a moment where we stop and gather our thoughts. We determine if that medication has proven to be helpful or not. We are saying that it's helpful if it's helping a target behavior, if it's slowing down a previously rapid weight gain pattern, or if we've achieved a 5% weight loss. So those of you all who do adult medicine, this 5% weight loss is a lot of what the adult side hangs on to as their mark for achievement of success. In kids, because we've got ongoing linear growth as well, we don't always have that weight loss, but weight stability with ongoing linear growth sometimes will really have actually shifted the tides quite a lot. The duration of use is important. It's not brief. We don't use these meds for, 2-3 months and call it done. The studies are showing that if you stop at 6 months, many of those kids will just float right back, and actually adults too, will just float right back to where they started. So that in a nutshell is the kind of medication treatment that we might consider. And then just in the
Dr. Williams, I'm sorry, can you unshare and share again? Thank you everyone for your patience.
I'd be happy to. Okay. So in the interest of time, there are a couple of medications that are specifically FDA approved for the treatment of pediatric obesity, and at those specific ages that I've listed. And the number 2 on that list is a major celebration. This is a very recently approved medication. We're using it very with great success in quite a few patients. So that liraglutide injectable has been a huge, tremendous step forward for us. Many off labels. Those of you guys, again, who know adult medicine, many of those are actually indicated and approved for adult treatment, but we're just using them off-label in children based on an age requirement. And some of them are just plain old off-label anyhow. I am going to move along just in case, by the way, anybody who's heard of lorcaserin, it is off the market and therefore not available whatsoever. And I am just going to wrap up with you all to talk just a moment on bariatric surgery for children and teens. And sometimes I have to stop and say, yes, for kids and teens. The kinds of surgeries that are performed for adults are safely done in childhood. We have the sleeve gastrectomy on the far left side is one of the most common ones. It's actually coming on and probably overtaken the gastric bypass. Depending on which center you work in, there's sometimes more preference toward one or the other. The lap band has fallen definitely out of favor, generally speaking. Very safe profiles in terms of the operative phase, the perioperative, and the long-term care, and really substantial weight loss seen from these treatments. So where it comes down to kids is certainly understandably, folks were hesitant to perform these surgeries on children until the data really proved the safety. What we've seen then, dear goodness, is that watchful waiting was really an approach. Do the best you can, pour on the nutritional changes, pour on the activity level changes, but sadly, many of those kids just did this up, 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 up. And so by the time they would have eventually reach a surgical table, their BMIs were sky high and so were their comorbidities. And we've really documented, and this is particularly in childhood and teenage years, that the outcomes for surgery are far better below 50. I will tell you, I see children, and this is not uncommon, BMI in childhood, 60, 70. I have much higher than that as well. So we don't want to be there before we are having a substantial intervention. And so now there's updated recommendations written very strongly, not just from the Bariatric Surgery Society, but also from the AAP as well, published in 2019, that the kiddos who are in class 2 obesity with a comorbidity, or 3, regardless of comorbidity, is a child who could be indicated for surgery, and that's regardless of age. I'm happy to take questions about that later on if folks have it. This is why we would perform surgery. This substantial weight loss, look at those trends. You're talking a year outside of surgery, an average weight loss of 30%. Of note, you get a substantial reduction in comorbidities if you lose 5%. So when we're talking 30%, you can see why we're really impressed with that result. And then just to be a pediatrician for a minute and show up my adult esteemed colleagues, kids do better after surgery too. They do better with the reduction of their comorbidities following. And so 83% reduction in terms of resolution of their diabetes 5 years out compared to 53% of you adult folks. Better numbers for hypertension, better numbers for dyslipidemia, although honestly, they didn't have a great adult to child comparison group, but it was still a trend better. And I wish that we had great fatty liver outcome data. That's actually coming off the presses kind of across the board for kids and adults anyhow. So that is it for us. These are our contacts. And